My name is Anthony Feinstein. I'm a professor of psychiatry at the University of Toronto. I work at Sunnybrook Health Sciences Centre in Toronto, where I have a clinical practice and I also run a multiple sclerosis research unit. I'm going to be speaking to you today on the important topic of depression in people with multiple sclerosis. Just a few slides on accreditation and credit designation. These are my disclosures. I acknowledge grant support from the Multiple Sclerosis Society of Canada and the Progressive Multiple Sclerosis Alliance, and I have various honoraria and book royalties. So these are the aims for today's talk. To recognize how best to detect symptoms of depression in people with multiple sclerosis, to describe the consequences of depression on the lives of people with MS, to discuss MRI changes associated with depression in people with MS, and to incorporate treatment options available to people with MS who are depressed and require treatment for this. Before I get into my presentation, I think there's a very important point to make. I'm going to be focusing on a condition that is treatable. In a disease for which there's no cure, symptom management becomes even more important. But in order to treat depression, as I'll explain, one has to make the diagnosis. You don't want to miss the diagnosis. What we have over here is a potentially remedial aspect to the disease that we can correct with adequate treatment. We also know that depression can exert a very significant effect on the lives of people with multiple sclerosis, as I'll make clear. And so keep this in mind as you go through today's presentation. It's so important that the diagnosis is not missed and that adequate treatments are provided to those with this disease. So how common is depression in people with MS? Well, we know that there's good epidemiological data to show that psychiatric abnormalities are very common in this condition. Here we have data from a large Canadian epidemiological study, 44,000 plus people with multiple sclerosis, over 220,000 healthy control subjects that came from 4 Canadian provinces. This was work completed by Ruth Anne Marie and her team out in Manitoba. And what they showed was that the annual incidence per 100,000 people with MS is as follows. Depression is by far the most frequent condition, followed by anxiety, followed by bipolar disorder, and then schizophrenia. Important point here is that all these disorders are more frequent in people with MS relative to the general population. And this is most notable for depression and anxiety. There's some evidence to show that anxiety and depression increases the severity of subsequent neurological disability in women, which is another important reason why you don't want to miss the diagnosis and provide adequate treatment, because we know that MS is a disease that predominantly affects women over men. This is in fact a telling observation, the next one, that the lifetime prevalence of major depression in people with MS ranges between 25 and 50% according to the study. Put another way, it's likely that 1 in 2 people with MS will experience a clinically significant depression over the course of their lifetime with the disease. This is very common. It's more frequent in MS than in many other neurological disorders. And later in my presentation, we'll explore potential reasons for this. So to make the diagnosis of what we call major depression, the American Psychiatric Association has come out with a set of diagnostic criteria. You'll be familiar with it. This is something called the DSM, the Diagnostic and Statistical Manual of the APA, and this provides the criteria for diagnosing mental illness. And the criteria for major depression are as follows. You have to have 5 or more of the following during a 2-week period. Depressed mood most of the day. A markedly diminished interest or pleasure in all your activities of daily living. You can have an appetite change with significant weight loss or weight gain. You may have difficulty sleeping, can't fall asleep, or you wake up early. The typical sleep pattern in someone who's depressed is that they fall asleep, but they have early morning waking because their REM, or rapid eye movement sleep, is diminished. However, depressed people lacking energy may want to sleep excessively. You can get hypersomnia. You sleep too much nearly every day. The individual may show some signs of agitation or retardation. This is observable by others. There's prominent fatigue with loss of energy nearly every day. There are feelings of worthlessness and excessive inappropriate guilt. So what that says is that your thought content changes. You have negative thoughts. You tend to doubt yourself. You feel guilty. Your self-esteem dips. You tend to think in a negative way, and you're pessimistic about things. You can also have the diminished ability to think or concentrate. And in the more severe forms of depression, there are recurrent thoughts of death. And so over a 2-week period, to sustain the diagnosis of major depression, you have to have 5 or more of the criteria that I've just listed. You'll notice that I've placed red stars next to some of these symptoms. And the reason for this is as follows. When it comes to assessing depression in the context of a disease like multiple sclerosis, there's the potential for symptom overlap. In other words, some of the symptoms of depression may be similar or identical to the symptoms of multiple sclerosis. And those are the ones that are flagged here with the red dots. So people with MS can have a change in appetite. Their sleep pattern can change. We know that fatigue is very common in people with MS. And as we'll discuss later, concentration may also be impaired. And so to the clinician, it's really important that you don't mistake symptoms of MS for symptoms of depression or vice versa. Because if you do, you can lose your way diagnostically. So one potential way to help you with this is to look at self-report rating scales for depression. Now, the man that you see on the screen over here has been called the second most famous psychiatrist after Sigmund Freud. And this is Aaron Beck, the father of cognitive behavior therapy. And Aaron Beck has a number of self-report psychometric scales available to detect symptoms of mental illness or psychological distress. And you see over here, there's one on the screen, once again with a red star next to it, called the Beck-Fast screen. And what Beck has done, he's taken the common symptoms of depression, but for this particular scale, he's removed the somatic or physical symptoms. So there's no question for sleep or appetite or fatigue or concentration, because we know that these might be confounded by the underlying medical and neurological condition. So the Beck-Fast screen for medical patients is a very useful short screening tool for depression in people with a medical illness. There are only 7 questions. It takes a few minutes to complete. There are various threshold scores that can allow you to assess the severity of your symptoms of depression. There is a similar scale. By the way, there are a number of additional scales that you see on the screen over here. This is the full Beck screen for depression. There's a Beck scale for suicidal ideation, hopelessness, the Beck anxiety and depression. So there are numerous psychometric scales that you can use for collecting symptoms of mental illness. But this one over here is specific for people with medical problems. There's another rating scale that I use in my clinic, which is called the Hospital Anxiety and Depression Scale. And similar principles over here. The somatic confounders have been removed. There's no reference to sleep or appetite, etc. You're just focusing down on the core depressive features. And what I like about the HADS, or the Hospital Anxiety Depression Scale, is that there's also a scale for anxiety, because you'll remember from one of my earlier slides, anxiety is also elevated. Rates of anxiety are elevated in people with multiple sclerosis. So this particular scale captures symptoms of depression and anxiety. There are 7 questions for depression, 7 for anxiety. It's easy to use. In fact, when patients come to my clinic, before they even see me, they fill out the scale on an iPad, and the results are there for me to see on my computer screen before the patient even gets into my office. So these are useful, quick ways of screening for symptoms of depression and anxiety. But a word of caution, you cannot diagnose a formal mental illness based on a self-report rating scale. So while the Beck-Fast screen and the hospital anxiety and depression scale are useful for you to use, you cannot sustain a clinical diagnosis just on patients filling out questionnaires. To arrive at a formal psychiatric diagnosis, you need to have an in-person assessment or an assessment via Zoom or Skype, in which you have the assessor look at the patient and interact with the patient and undertake a structured interview. Nevertheless, these self-report scales are very useful in a clinical practice, and of course, we always use them for research. So why is depression so important? We'll see a number of reasons up on the screen there. I'm just going to start with this one over here, get it out the way early, quality of life. Depression is a significant contributor to poor quality of life. It's one of the most robust findings in the behavioral literature. You cannot enjoy your life when you are depressed. Depression is a significant, has a significant influence on a person's quality of life. But depression is important for a number of other reasons as well. We see here suicidal intent and completion. So this is a topical review that I wrote with a student of mine a few years back, looking at the question of MS and suicide. And we reviewed all the literature, and there is clear evidence based on something called a standardized mortality ratio that the rates of completed suicide in people with MS are approximately twice what they are in the general population. The reason why an SMR, or standardized mortality ratio, is helpful is because it actually controls for things like age, because suicide rates will vary according to age, etc. So there's fairly compelling evidence that MS, for a multiplicity of reasons, leaves the individual at risk for suicide. And of course, suicide is the worst possible outcome in medicine. We also know that people with MS are prone to suicidal thinking, and suicidal thinking can be the harbinger of a suicidal attempt. So this is a study that I completed a few years back at an MS clinic, and I showed that about 1 in 3 people with multiple sclerosis over the course of their lifetime will think about suicide. 1 in 3. Far fewer people will attempt it, thankfully, but you can see over here that about 6% of people in this particular sample had actually attempted suicide. So this is very common. What I showed was this, and that this is cause for concern, that 35% of suicidal patients had received no treatment for their underlying mental difficulties. That 2/3 of the patients who had a diagnosis of major depression were not receiving treatment. Of the 9 patients who had attempted suicide and who were depressed, 4 had never been given antidepressant medication. They were just not getting treated. And these data are not unique to a clinic in Toronto. They fit with a study completed by David Moore a number of years back at UCLA, who showed that over half the depressed MS patients in a neurological clinic were not receiving antidepressant medication. And of those depressed patients on treatment, 1/4 were receiving subtherapeutic dosages. So what you see over here is that some very sick people with depression are not being picked up, even in an MS clinic. And should they be detected, many are not being adequately treated. Depression is also important because it can influence cognition. Now, my talk is not going to focus on cognition, but to summarize a few salient points, we know that cognitive difficulties will affect between 40 and 90% of people with MS according to your disease type. So in relapsing remitting MS, the rates of cognitive impairment are about 40%. As you get up to secondary progressive, 70 to 80% of people are affected. And in primary progressive MS, the numbers may be as high as 90%. So cognitive difficulties are very common in people with this disorder. They have a negative effect on people's functioning. They prevent someone from obtaining work or sustaining work. They interfere with activities of daily living. So cognition is a very significant difficulty for people. And it's possible that depression might make this worse. And it can do it in one of 2 ways. The first theory is that depression uses up cognitive capacity. So that says we have a limited amount of information that we can hold online. We have a limited cognitive capacity, but in the context of depression, we have fewer attentional resources that allow us to access what's in our cognitive capacities. Like our cognitive capacity shrinks because of depression, leaving us with less abilities to perform capacity demanding tasks. The second theory is that depression may slow our processing speed. Now we know that processing speed or impaired processing speed is the hallmark cognitive difficulty for people with MS. Cognition slows. People with MS process information slower. If you bring in depression, it may get worse. It further reduces your processing speed. We also know that this is going to be linked to the severity of the depression. This was a very simple but elegant study completed by Demery and colleagues when they had a look at the relationship between depression, mood, and cognition. They looked at 3 groups of people with MS, those who were very depressed, those who were mildly depressed, and a group of healthy controls who had neither depression or multiple sclerosis. And they gave them a short battery of cognitive tests that included a test of memory, the selective reminding test, and a test of attention and working memory called the PASAT, the Paced Auditory Serial Addition task. And what Demery and colleagues showed was that it was the most depressed individuals who had the greater cognitive deficits, more than individuals with mild depression, who in turn were more impaired than the healthy controls. So it would appear as though there's a threshold over here that if mood or depression is going to affect your cognition in a negative way, you've got to have a significant degree of depression. We extended this in an interesting study looking at distractibility in people with MS and how might depression affect this. And the theory behind this study is as follows. When someone comes in for cognitive testing, the tester often puts a sign up outside the door saying, "Quiet, please, testing in progress." So the tester tries to create an ideal atmosphere within the office, one of silence and quiet, so that the individual with MS can focus on the task without distraction. However, we know that this is not a real world situation. We don't live in a quiet world. There are multiple distractors. There is noise all around us. Things are going on all the time. Offices are busy. Telephones are ringing. There's background ambient noise. These are the kind of things that can distract us. And the question that we tried to address was this. If we want to make our cognitive results meaningful in a real world context, let's see whether we could bring in some distractions, see how they affect cognition, and let's see how they do it in the presence of depression as well. And by doing so, our results have what we call ecological validity. In other words, real world significance. And we focused on processing speed because we know that this is the cardinal cognitive difficulty in people with MS. And we compared processing speed in people with and without depression, and we brought in distractions. So how did we do that? Well, we had 102 people in the study, all with MS. Half of them completed a test called the Symbol Digit Modality Test. I'll show you what the test is like. It's a very sensitive test of processing speed. Half did it with distractions and half without. And the distractions that we brought in were a telephone that rang or a car horn that sounded. But because we did the testing on a computer, we could standardize the distractions. So everybody would hear the telephone and the car horn at the same time, at the same volume, and for the same duration. So we could control that. And all our subjects also completed the HADS, the Hospital Anxiety and Depression Scale, where we recorded symptoms of depression and anxiety, and we showed that 28% of our sample were depressed and 50% were anxious. So what you see in front of you here is the computerized version that we've developed of the Symbol Digit Modalities Test. And what you see over here are 2 rows of boxes with numbers 1 to 9. And here you've got 9 different symbols above the boxes. Here we've got 9 boxes below with the symbols in a different order. And the task of the person doing the test is to match each symbol with the code here, with the number, as quickly as possible. So this symbol over here matches to 7. This matches to 2. This one to 5, and so on. So the person is sitting in front of the screen, a buzzer sounds, and they have to match the symbols to the numbers as quickly as they can. When they get to the end of the line over here, this matches to 3. This line over here goes blank, and the symbols come back in a different order, and you start up again, matching them to the numbers as quickly as possible. And you go through 8 iterations of this before the test ends. So that's a version of the symbol digit modalities test. However, to bring in the distractors, you see over here an icon, and during the assessment, a telephone would ring. Or at another time, a car horn would sound. And to repeat, every individual would hear the telephone at the same volume, with the same duration, and the same time of the test. So what do the results show? There are a lot of numbers on this, and I'll walk you through it. In this column, we've got those individuals who are depressed, and here we've got those who are not depressed. When you follow across here, we have the symbol digit score, here with no distractors, and here with distractors. So starting over here, you can see that in the group who was not depressed and without distractors, it took someone with MS approximately 15 to 16 seconds on average to complete a line. When that person became depressed, or if the group was depressed, you can see that the timing over here actually increases. Goes up to almost 17 seconds. So depression by itself is slowing down someone's processing speed. Here we see the non-depressed group doing the test in the presence of a distractor. And it took them about 16 seconds per line. So you can see over here, no distractors, no depression with distractors, and yes, the performance gets slower. We'd expect that. But then go across and look at the numbers over here. This is a group that's depressed with distractors. It took them on average 22 to 23 seconds to complete a line. If you compare this, 23 seconds to 15 seconds over here, this is an almost 7-second difference for people who are depressed in the presence of distractors. These results are clinically very significant. When you look at the impairment rate on the symbol digits, so this is failure rate, we can see over here that about 30% or 1 in 3 people failed the test if they were not depressed with no distractors. When we bring in distractors and you're still not depressed, the failure rate goes up by about 5%. The failure rate in people who are depressed jumps to 50% even in the absence of distraction. So we know that depression by itself can slow things down. But bring in distractors and you can see that almost 3/4 of the sample failed this test if they were depressed and if distractors were present. We never found the same results for anxiety. So this appeared linked to depression. So what we can conclude from this is that depression, but not anxiety, further impeded processing speed in people with MS, particularly in the presence of distractors. And given that distractors are ubiquitous in the real world, they're everywhere, these findings highlight the potential influence of depression on cognition in the workplace and in the home. And I'll give you one practical example of how this plays out in my clinical practice. People come see me because they're worried about their cognition. We undertake cognitive testing, and the results are normal. And we give them back what is a good result, and they seem perplexed. They say, well, if my results are normal, why is it that I'm not functioning at work? Why can't I function in my busy office? And the answer may well be because the testing took place in a quiet room where we optimize testing conditions. Move into the real world, it's going to be very different. And if you happen to be depressed, you're going to have significant difficulty managing an environment like that. So let's move on to brain imaging, because this is fascinating. We know now that depression in MS will be multifactorial when you come to finding a cause. I've said already that MS is a disease without cure. That's hard for patients to accept. It's a disease of great uncertainty. You never know when you're going to have your next relapse. That can be a factor that can lead to depression. Depression will also be associated with things in a person's life like loss of job, or poor earnings, or financial worries, or relationship difficulties, or difficulties with your children. So there are going to be multiple things associated with depression. The psychosocial influence on depression is profound and well recognized. I'm not going to address it here. I'm going to focus on brain imaging because it also gives us clues as to why the rates of depression may be so high in people with multiple sclerosis. So this is an important study. You'll see over here that it dates from 1997, 13 years back, but it was the very first MRI study that showed a link between the presence of brain lesions and depression. And what the researchers showed was that lesions in the left arcuate fasciculus were associated with depression. So here we have the plots. We can see here Beck depression scores. You remember Beck, the man with the bow tie. As the depression scores go up, here we see the lesion scores over here. As the number of lesions in the arcuate fasciculus go up, we start seeing a significant association. More lesions in this part of the brain, more likely to become depressed. Now, the arcuate fasciculus is an interesting finding because it's not part of the limbic lobe, not part of the limbic brain, the emotional brain. The arcuate fasciculus is a large band of fibers that links the limbic lobe to a part of one's cortex called the dorsolateral prefrontal cortex, which is certainly relevant with respect to mood, as I'll show you later. So what we have over here is a very early indicator of an association between the presence of clinically significant depression and the presence of brain lesions as detected on MRI. However, this early study showed that these lesions by themselves could only account for about 17% of the variance. So yes, the lesions were important, but really not that important in trying to understand why this group had become depressed. Other factors were at play. My group then went on and did a much more detailed MRI study in which we looked at the presence of lesions, the hyperintense lesions, also the hypointense or the black hole lesions, which are indicative of atrophy. And we also had a look at generalized brain atrophy, or shrinkage of the brain, reduced gray matter volume globally and in regions, very specific regions. And what we found was that these structural changes, lesion volume hyperintense and hypointense in the left medial inferior frontal cortex, and atrophy in the anterior temporal region, was significantly associated with depression. And when you added up the hyperintense, the hypointense, and the atrophy findings, this accounted for a significant percentage of the variance, almost reaching 40%. So yes, the lesions are important, but atrophy in certain limbic areas is potentially even more important. This is a study done by Stefan Gold's group in Germany a number of years back, and they did a very detailed analysis of the medial temporal lobe, or the hippocampus, which is considered an important brain region with respect to depression. And you can see over here, this is a sagittal MRI, in other words, an MRI looking at the brain from the side on, and you can see that very thin slices were completed, focusing down here on the medial temporal lobe. And you can see it displays the medial temporal lobe anatomy in beautiful detail. This is the hippocampal anatomy over here, and the hippocampus is divided up into subregions, which are color-coded here. Area 2 and 3, area CA1, the subiculum, the entorhinal cortex here in blue. And what this group did, they had a looked at individuals who were depressed and those who weren't, people with multiple sclerosis who were depressed and those weren't, but also a healthy control group who had neither depression or multiple sclerosis. And we see the findings here on the Beck depression scale. And the group in blue refers to those who are depressed and who had MS. The white group refers to those who had MS but who weren't depressed, and the black bar refers to the healthy subjects. And focusing on this area over here, area CA2 and 3 within the hippocampus, this area marked out in red, you can see that the individuals with MS and depression, this group over here, were much more likely to have a reduced brain volume over here, significantly so compared to the MS individuals who were not depressed and the healthy controls. This was the crucial area within the hippocampus, area CA2 and 3. What the group also did was they had a look at serum cortisol levels, and cortisol is a stress hormone, which obeys what we call a circadian rhythm. So people who are not depressed have high cortisol levels in the morning when we wake up at 9 a.m., And when we go to bed at 11 p.m., the numbers have fallen significantly. Our cortisol levels go down. And this is a normal circadian rhythm. But there's evidence to show that in people who are depressed, the circadian rhythm is disturbed, that the level of cortisol does not go down as much, or maybe not at all, in the people who are depressed. And so what this research group did was that in addition to completing this MRI, they obtained cortisol levels from their sample at 8 a.m., 4 p.m., and 9 p.m. There's day one. They repeated it again at 8 a.m., 4 p.m., and 9 p.m. And the y-axis over here, you see the concentration of cortisol. And what you can see really nicely is that in the healthy group, now the MS or depression, high cortisols early in the morning as you'd expect. By the time you get to 9 p.m., the levels drop as you'd expect. The person wakes up the next day, the cortisol levels are high again, a good circadian rhythm. This is slightly disturbed in the people with MS who don't have depression, but there's a very different curve in the people with MS who do have depression. The slope is much gentler. By the time they go to bed in the evening, or by the time they get to 9 p.m., which might be an early bedtime for them, the levels of cortisol are still quite high. So there's a disruption in the circadian rhythm. And this high level of cortisol is linked to the selective atrophy of the hippocampus, very specifically in region 2 and 3. So really fairly compelling evidence over here that in a group that's depressed, we've got some biological markers of why that might be. One of my studies took the brain imaging a little further, and we brought in something called diffusion tensor imaging, which allows us to look at normal appearing brain tissue. And this gives us certain indices like fractional anisotropy and mean diffusivity. And the way we do it over here is we have our brain MRI, we parcellate or we remove the lesions, we then separate the brain into white matter over here, or gray matter. And this is normal appearing white matter, normal appearing gray matter. We have removed the lesions. And then we divide this up anatomically into brain regions through using computer programs. And so in each one of these color-coded regions, we can look at normal appearing white matter here or normal appearing gray matter here and extract some useful information on this brain tissue that is normal to the naked eye. So we applied this diffusion tensor imaging technique to people with multiple sclerosis, and the findings were interesting. We're going to look at the FA values over here, fractional anisotropy, which refers to the ease with which water diffuses longitudinally along axons. And as the axons become damaged, this linear or streamlined diffusion becomes disturbed, and your FA values go down. So low FA values are bad, high FA values are good. And the best possible FA value is 1, and the lowest gets close to 0. So we applied this mask to the people with MS who were depressed and non-depressed. We used the Beck Depression Inventory as a marker of depression. Anyone whose scores were greater than 19 were considered depressed, less than 19 you were not depressed. And what we can see is that when we looked at the left anterior temporal lobe and limbic region, we showed that the group who was depressed had a significantly lower FA value compared to the group that was not. In the same area, when we looked at the normal appearing gray matter and we looked at mean diffusivity, that's another index of how is diffusion taking place in the brain. If you've got an inflammatory process with a lot of debris from it, diffusion is going to be more difficult. And so your mean diffusivity numbers go up. So in this case, high numbers are bad and low numbers are good. You can see that in the depressed group over here, once again in the left anterior temporal lobe, the mean diffusivity number is significantly higher than it is in the non-depressed group. And over here, something of particular interest, we looked at those individuals who had a very heavy lesion load in the right inferior frontal. We know this, the right inferior frontal lobe is an important brain region with respect to the anatomy of depression. And in this particular sample, there was a significant amount of lesions in this area, particularly in the depressed group. But what we did was we applied diffusion tensor imaging and drilled down within the lesion to extract mean diffusivity values from within the brain lesion. And what we showed over here was that once more in the group that was depressed, the MD scores were significantly higher than they were in the patients who did not have depression. So what these data show is that even by looking at normal appearing brain tissue, we can extract information of change, pathological change, in people who are depressed that give us clues as to why rates of depression are so high. So what I've shown you over here is structural brain imaging. When we move to functional MRI, we find complementary findings. And this is a study looking at cognitively intact people with MS. They were not depressed, they were not anxious, and there was also a healthy control group. And brain responses were recorded in all participants while they executed a task that consisted of processing emotional stimuli relative to neutral stimuli. And the emotional stimuli were facial expressions. People were shown facial expressions that had an emotion. They were also shown neutral facial expressions. And while the healthy subjects, the people with MS, looked at these faces, they were in the scan, and the functional brain activity was mapped. And these were the findings, that the people with MS displayed significantly greater responses within the ventrolateral prefrontal cortex compared to controls. So a lot more activation in this particular region of the brain, a limbic area again, relative to controls when looking at the facial expression. And people with MS relative to controls showed a lack of functional connectivity between prefrontal areas, the medial prefrontal cortex over here, and the ventrolateral prefrontal cortex. So a lack of connectivity between these two frontal areas and the amygdala. And the amygdala is also an important brain region in processing emotion. And you can see here that the healthy controls, this functional connectivity is intact. In the individuals with multiple sclerosis, it's not. And because of that, you get an upregulation of response. And over here, the brain activates excessively in response to the stimuli. What makes the study so significant is that this was a group that didn't have clinically significant anxiety or depression. And yet, the neural network that is important with respect to modifying mood appears to be defective or weaker. And this suggests an innate vulnerability in people with MS, that potentially what's happening is that you haven't yet become depressed or anxious, but the brain networks are not functioning as they should, and in response to a negative life event or a stress, your threshold for developing depression is significantly reduced. And there's some confirmatory evidence of these findings from another study over here, in which this research group, once again using functional MRI, had a look at connectivity between the amygdala and the hippocampus. You'll remember the importance of the hippocampus from the earlier study that I showed you. So they looked at the connectivity between the amygdala and the hippocampus on the one hand, and frontal regions on the other, the dorsolateral prefrontal cortex and the ventromedial frontal cortex. Same kind of stimulus. They showed individual an atlas of facial expressions in which people would look at angry faces or sad faces or neutral faces. Here we have the mapping of the amygdala. Here we have the ventrolateral prefrontal cortex. Here we have the dorsolateral prefrontal cortex. And using fMRI, the researchers looked at the connectivity between these regions. What they showed was that in the group who had multiple sclerosis, relative to healthy controls, so the MS group here is in, what color is that? I'd call that a yellow. There is excessive activation in response to angry faces, sad faces, even a neutral face. We've seen the brain activating excessively, excuse me, relative to the healthy controls who we see here in red. And in the cartoon at the bottom here, we're looking at connectivity. And once again, we see a similar pattern here in the MS group. There is less connectivity between the amygdala and the dorsolateral prefrontal cortex when it came to processing anger, sadness, or even neutral facial expression. The connectivity was stronger in the healthy control groups. So what we see are complementary findings. We know that the lesions are important. We know that atrophy is important, but the structural change disturbs function, and it breaks down connectivity between pivotal brain regions that play a role in controlling mood. And when we look at the cumulative weight of the imaging data, we now have compelling evidence that in some people, the depression is directly linked to these brain changes. Why is that clinically important? Because a patient comes to see me with MS, and they're depressed, and they say to me, "Doc, I know I've got MS, but my MS is not too bad. I'm still walking. You know, my family life is good. I'm happily married. My kids are fine. You know, we don't have any monetary worries. And yet I'm still depressed. You know, my life is okay." And the answer is, you're probably depressed because of the brain changes. Now, we're not yet at a level where we can look at an individual MRI and say, this is why you've become depressed. But there's compelling group data from what I've shown you over here, that for some people, these brain changes, both structural and functional, underlie their depression. That you don't have to always bring in a psychosocial explanation for accounting why they're depressed. For the last part of my talk, I want to turn to treatment. So to summarize, we've gone through the important symptoms of depression and how you can detect those using self-report rating scales like the Beck-Fast screen or the Hospital Anxiety and Depression Scale. We know that depression is important because it leaves individuals at risk for suicide, that it can further compromise their cognition. We've seen the importance of brain MRI in trying to understand a mechanism as to why people with MS can become depressed. We acknowledge, of course, that psychosocial factors are very important here as well. And now we come into this critical variable of how to treat depression. So here's some more interesting MRI data. This was a study looking at stress management. Individuals with MS were randomized into two groups. One received 24 weeks of treatment focusing on stress management. The other was given no specific treatment. Individuals underwent brain MRI and they were given contrast enhancement as well, gadolinium. And what the study showed was that in those individuals who got stress management, they had less contrast enhancing lesions and indeed fewer T2 lesions as well. So what we see over here is we've got the group in blue got the stress management therapy, the group in red did not. Over here on the y-axis, we have percentage-free new lesions, and we can see that in the group of stress management, they have a greater percentage free of gadolinium-enhanced lesions and less T2-weighted lesions in general. We see this very nicely shown longitudinally. We have time over here, and here we've got percentage-free new lesions. And we can see that this group that's getting stress management, much less likely to have contrast-enhancing lesions. And then the study ends, and the two groups come together again. So we can see how a psychotherapy targeting stress management can have a significant effect on a brain MRI. But what makes this, in many ways, even more challenging is that despite this group benefiting from stress management, despite the MRI looking a lot better, there were no benefits with respect to mood. So stress management alone, it would appear, is not enough to treat someone's depression. We need to look at antidepressant medication to begin with. So the earlier study that shows some compelling, albeit weak data, was one completed by Randy Schiffer and Margaret Wyman, we'll see back in 1990, with the old tricyclic drug dizipramine. And here we have the data, small sample, 14 people got dizipramine, 14 did not, they got placebo, and they followed the group for a number of weeks. And if you look down the side over here, you can see that more people getting dizipramine improved than those who got the placebo. So a positive result with the medication, but there were side effects linked to the tricyclic drug. And for certain individuals, that stopped them reaching a therapeutic dose of the drug. So side effects were a limiting factor. The next study looked at a newer drug, paroxetine, one of the selective reuptakes, selective serotonin reuptake inhibitors, as a treatment for major depression. And it was a double-blind, placebo-controlled randomized trial, smallish sample, 42 subjects. The dose of paroxetine varied from 10 to 40 milligrams, 12 weeks of treatment. The primary outcome was a Hamilton rating scale, number of secondary outcomes. And in fact, the study did not meet their primary outcome measure. It fell short. And once again, you can see some significant side effects here: nausea, headache, dry mouth, sexual difficulties, the anticholinergic side effects linked to this medication. When you look at the data over here, the primary outcome measure was a 50% reduction in HAM-D scores, and they didn't meet it. There was a trend, but they didn't meet it. When they kind of retweaked an outcome measure, saying, well, let's get our HAM-D scores down to less than 7%, you start seeing a significant value emerge over here. And when they looked at the actual diagnosis of major depression, where you're less likely to show features of a major depression on treatment, in fact, there wasn't a treatment effect over here. So what we see over here is there is some tentative data suggesting that perhaps the medication is effective, but not a hugely positive result, and once again, concerns about side effects. There's a Cochrane review looking at antidepressant medication, and it will probably come as a surprise to you to know that despite the frequency of depression in people with MS, and the effect that depression can have such a negative effect on people's lives, there are only 3 studies that make it into the Cochrane review as having a good enough methodology. The zipramine study, which I went through with you, the paroxetine study, and a really interesting study comparing sertraline, which is an SSRI, similar to paroxetine, with cognitive behavior therapy. The conclusions of the Cochrane review was that medication was partly effective, there were troublesome side effects. But let's go and have a look at this study over here, looking at sertraline versus CBT, or cognitive behavior therapy. So what is CBT? It's a short-term, goal-oriented psychotherapy, a hands-on therapy, a practical approach to problem solving, and its goal is to change patterns of thinking or behavior that are behind people's difficulties. And if you can change this pattern of thinking, your mood improves as well. So very kind of concrete, goal-orientated, focused psychotherapy. And this was a study that looked at telephone-administrated CBT, so important because you can give this over the telephone. People don't have to come into the clinic. So telephone-administrated CBT versus individuals who got a different kind of therapy, just some supportive emotion-based therapy over 16 weeks, 12 weeks of this. Sorry, a 12-month follow-up period and 16 weeks of treatment. And the outcome was a Hamilton Depression Rating Scale and a structured interview to get the diagnosis of major depression. You can see here that very few people dropped out. So this is a therapy that people accept. Of 127 individuals, only 5% dropped out over the course of these 16 weeks. And the group that got the telephone-administered cognitive behavior therapy did a lot better in terms of the Hamilton Depression Scale and other outcome measures over here. The beauty of this particular treatment is that there are no side effects linked to cognitive behavior therapy. In a separate study, the lead author here, David Moore, also had a look at CBT versus sertraline, the drug that I mentioned earlier. And he showed that CBT was just as effective as a selective serotonin reuptake inhibitor in treating depression in people with multiple sclerosis. We know now that CBT is available online. So you don't have to come into the hospital. You don't have to do it over telephone. You can do it yourself from your computer. And this is a study that showed that this can be effective as well. The program is called Praxis. This was a randomized controlled trial. Here we have depression scores on the y-axis with the Beck Depression Inventory. Here we have baseline. We have follow-up at 9 weeks. And you can see that the group that got the intervention, the Praxis, their Beck scores declined significantly, whereas in the control group with no treatment, there wasn't a significant change. So individuals using a computer that has a CBT component were able to bring about an improvement in the mood if they were depressed. Here you see some additional data from this study. Not only did scores go down on the Beck Depression Inventory, the individuals who improved had less negative beliefs about themselves, had a better sense of psychological well-being, and their sense of motor fatigue improved as well. There were knock-on benefits in terms of fatigue. So, there's fairly compelling evidence now that CBT can be very effective. This is a result of a meta-analysis in which we see over here where the CBT is given given to individuals or given in a group setting or given via computer. It's effective. We've got here the odds ratios, and you can see that just about every study, just about every study has a positive odds ratio. The effects, the effect sizes are not enormous. There's a modest effect size over here, and there isn't any negative study. Basically, they're all in the positive range over here with an effect size of about 0.5. There's another intervention called mindfulness-based training, in which individuals are taught to relax and control their thoughts. So it's like a variant of CBT, and this too can be very effective in helping people with depression. Here we have the data from a mindfulness study in people with MS. And we can see over here, this is the group that got usual care, the dark dots over here. This is a group that got mindfulness. And you can see that when it came to depression scores on this particular rating scale, the SESD, there was less depression in the mindfulness group. 6 months after completion of the study, the benefits were still there. The group that got mindfulness were less depressed. A secondary outcome measure over here was fatigue, modified fatigue impact scale. In fact, mindfulness helped fatigue as well. You can see benefits with respect to fatigue, which were maintained by 6 months. What about exercise? How does that help depression? So there are a number of studies over here with many methodological weaknesses, but once again, when you look at effect size, it's generally positive that depression can be helped through exercise with effect sizes that are modest again, 0.3 or 0.4. The American Academy of Neurology has concluded that of all the depressions available now, the best treatment for depression in people with MS is cognitive behavior therapy. We're moving into the age of non-invasive brain stimulation to treat various conditions. This is very prevalent. Its use is very prevalent in mental health settings. It's also being applied to people with multiple sclerosis. And a review of transcranial magnetic stimulation, repetitive transcranial magnetic stimulation, ECT, basically shows that these are safe treatments. And while there's not much data with respect to transcranial magnetic stimulation as yet, that data is coming. There is, however, some data with respect to electroconvulsive therapy. Now, to put it into context, this is only used for those individuals who are very depressed, who might be acutely suicidal, who've not responded to medication, and who can't respond to cognitive behavior therapy. So you kind of use it as the final kind of treatment for people with very severe, potentially life-threatening depression. And the study over here, you can see that it's actually extremely effective. So these are individual case reports. So each one of these over here represents, a single patient. And you can see over here that when you look at the response rate over here, the majority of people improve very well with electroconvulsive therapy. You can see it's given predominantly for depression, etc. In terms of side effects, really very little. Very little. Change after treatment, you see maybe a slight change in gait disturbance over here. This individual developed delirium, which is short-lived. The majority of people tolerate the procedure very well. But to repeat, that's the end of the road treatment for very severe depression. So my prediction is this: within 3 to 4 years, the therapeutic approach to depression and MS will be revolutionized by non-invasive brain stimulation, such as repetitive transcranial magnetic stimulation. This will be shown to have fewer side effects of medication. There may well be some added cognitive benefits from this treatment as well. And the demands may be less than 16 weeks of therapy that you must have with CBT. So in conclusion, there are easy to use, quick, validated screening measures for depression in people with MS. Easy, quick, and validated. We know that brain MRI metrics can account for close to 50% of the depression invariance, so the MRI can be very important in trying to understand why so many people develop depression. There are effective treatments for people with MS who become depressed. Cognitive behavior therapy is preferred to medication. And CBT can be given by telephone or possibly self-administered by computer. So my take-home message to you is a very clear one. Screen your patients for depression so that you don't miss the diagnosis and you don't miss a potentially treatable disorder. Thank you for your attention.